welcome to another insightful episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we are diving in deep into a critical topic in head and neck oncology, salivary gland tumors. Though these tumors are relatively rare, they account for 3 to 5% of all head and neck cancers, making their early detection and management extremely important. And to guide us through this complex topic, I have with me Dr. Arsheed Hakeem, a highly accomplished head and neck oncologist surgeon with over 24 years of experience. He has an extensive background in oncology surgery and has trained at the National Cancer Center Hospital in Tokyo, which is in Japan, and has over 50 publications in national and international journals. It's truly an honor to have you on the show today. Welcome.
Thank you for making me attend this podcast.
So now, let's begin with the foundational understanding. Could you provide an overview of salivary gland tumors, highlighting the different types, their prevalence and common presenting symptoms, and also how can healthcare professionals ensure early detection, and what are the key challenges in distinguishing benign from malignant tumors?
So now today we are talking about salivary gland tumors. Now, salivary gland tumors, we have two types. One is the major type and another is the minor salivary glands. These major types we have paired, means we have parotids on both sides of our face. Below the mandible we have submandibular, and if you see inside we will have sublingual glands. They are all major are paired. And now the minors, there are multiple minors, enormous numbers. If you see from the tip of your nose up to upper aerodigestive tract and trachea, esophagus, you will see numerous small clumps of these tumors, glands everywhere. Now, the basic role of these salivary glands is to secrete secretions, what we in common terms call saliva. Now, what is the role of this saliva? It will facilitate your digestion, lubrication, swallowing, protection of your mucous membranes, which are pink lining inside. They protect your teeth. They help in flushing out any foreign material that adheres to these mucous membranes. Apart from that, they have enzymes in them, like they have lipases or amylases, so they help in digestion, and they have antibacterial things in them, like immunoglobulin A or leukotrienes. So overall, the basic fundamental principle of these is to secrete saliva and keep you healthy. Now, as any growth can occur in any part of the body, any cell, here also cells may multiply uncontrolled, which is not under the control, which just goes uncontrolled, and then they result in the formation of tumors. And the classification of these tumors is quite confusing. WHO has classified them into some 20 types, and it is still evolving. Maybe next year, years ahead, we will have different types, because as we are getting wiser about their pathology or about their biological differentiations, we are adding these tumors. So one thing common to all these things is that if you see these tumors, they will be found in the higher age group, around 5th and 6th decade of the life. And they, as you said in the beginning, that they are rare. The rare definition of rare tumor is that the incidence should be less than 4 per lakh population. So they are, just you said, 3 to 5%. I say 3 to 6%. So they categorize in rare tumors. Mm-hmm. And overall, if you see, only 0.5% of them are malignant or cancers. Now, how do they develop? There are certain risk factors for their development. One of the commonest is low-grade radiation. Low-grade radiation, that we know, we have all gadgets in our home, ACs, fridges, and all. They have electromagnetic waves, they have radiation, low-dose radiation, exposure to that. Even some say that even exposure to the electromagnetic radiations by your cell phones, they may result in these tumors. Second most common factor is tobacco use. Third is use of, if you see in the nasal cavity, the most common salivary gland tumors, they can be because of the people who work in these wood industries, especially softwood industries, or people who work in the leather tanning industries. Exposure to the chemicals may result in that. Or certain immunodeficiency conditions may cause more presence of these tumors, like HIV virus there, or what you in simpler terms called AIDS. Now, we are a lot of emphasis is being made on the genetic causes, and people are and more research is being developed in these tumors to identify the genetic causes. Why these tumors are happening? There are a lot of research going on the estrogen receptors, progesterone receptors, androgen receptors. Now, what we have evidence for is that in certain tumors, like benign tumors, we may have translocations of genes, which in the most common two translocations which we know are exist in these some tumors is 8q12 and second is 12q13-15. Means there's translocation of gene that results in regenes. There's one gene that has been identified is the pleomorphic adenoma G1, and second is the HMGA2, what we call a high motility group 80 hook 2. So these two translocations are well known in these tumors, especially in the benign zone. Now there are a lot of tumors. Let me name few. Like most common we see is the pleomorphic adenoma, which is a benign tumor, mixed tumor. There can be Warthan's, which is benign, lymphoepithelial tumors, and multiple adenomas like canalicular, basal cell, myopathy. It's all confusing to the layman. And then there can be their counterparts. Like we may have mucoepidermoid carcinoma, adenoid cystic carcinoma, carcinoma expiomorphic adenoma, if a cancer develops in the pleomorphic adenoma, or acidic cell tumors, they are all malignant. Or even rarely we may have a squamous cell cancer in these tumors. Now, tumors are of two types. One is the high grade and low grade. Low grade are indolent, slow growing, they don't metastasize, and they have an excellent prognosis. While as a high grade tumors, they behave aggressively, they will metastasize to the lymph nodes, and they will metastasize to the different parts of the body, and they are always high risk to the patient. Now, if we see, there's not much difference between a benign tumor and a malignant tumor. Clinically, we can differentiate. Usually benign, they present as an asymptomatic mass that is slowly growing. And there won't be any facial nerve palsy, there won't be any neck nodes associated with it, there won't be any infiltration of the skin or any other surrounding non-parotid structure. While as in case of malignancy, clinically you may get a hint that there is a cancer in this mass, that if it is a fast growth, if you have an associated ipsilateral same side neck nodes associated, if there is a facial nerve deficiency or paralysis, that gives an indication. Or if there is an invasion of the skin, or if there is that this mass anywhere gets fixed, that there is a very high chance of a malignancy in this. That way, on clinical basis, we can differentiate between a benign tumor and a malignant.
Yes, I think that's a very insightful breakdown, doctor. But can you focus a bit more on how can healthcare professionals help in early detection, and how important is early detection of these tumors?
So most of the tumors, they will present as I told you as an asymptomatic disease. So any person who has a lump in the face, down here, or any other part of the body, he should get examined very fast, just to determine whether there is not some bad disease developing in that. Now, on the part of the healthcare workers, how they should work these tumors out. Now, I will never treat a tumor of the salivary gland without getting a proper diagnosis and without getting an extent of the tumor. By proper diagnosis, I mean an FNAC diagnosis. FNAC diagnosis is very important because one, it has very high sensitivity and specificity. Sensitivity runs up to 96% and specificity is around 98%. So they will help you in distinguishing a non-cancerous mass from a cancerous mass. Like there can be some non-cancerous mass or some other cancers like lymphoma, which we treat with the chemotherapy. We may not need surgery, or a tuberculosis, like mycobacterium tuberculosis. There we don't use surgery. So it will help you in distinguishing a non-neoplastic mass from the neoplastic mass. And if it picks up a neoplasm, if it picks up a tumor, then you can work them up better. Now, FNAC, whenever you send a patient for FNAC, tell them that you should label it as a Milan group, what it has classified. Now, there are some other reasons why I will never skip FNAC. There are some doctors who say a superficial parotidectomy is as good as doing biopsy. Just do a superficial. No, I will never take my patients without doing an FNAC. Because there are some studies, the three I will mention. One was by the Heller et al., which says that if you do a pre-operative FNAC, our management plan gets modified in around 35%. And there was one more publication in laryngoscopy in 2018, which again showed that around in 19 patients, we may modify our plan depending on the FNAC. And there is one study by Lin, which shows that if your FNAC is positive, you can do upfront neck dissection, treat them better. You have more chances taking this tumor out completely. That's having negative margins. So once a week you tell your pathologist to give the report as per Milan classification, in which we have 6 categories. Category 1 is a non-diagnostic. They do an FNAC, they take some cells, and it comes out to be non-diagnostic. It's not that you have your FNAC has come non-diagnostic, you will leave that patient. There is a risk of malignancy in such cases around 20%. I do an MRI in such cases. If it's possible, do an MRI or a CT scan. See the tumor. That will give you a lot of criteria on which you can determine whether you need a repeat FNAC or you need a true cut, where we can do a bigger needle in biopsy and we get a better results. So never leave these non-diagnosed. If it comes as Milan one, never leave them. Second category is non-neoplasm, where they say you that is not tumorous, but then there is again a chance of 10% of these cases turning out to be a malignant, a risk of malignancy. So again, work them up fully, do an MRI, and if needed, a true cut biopsy to finalize the diagnosis. Third category is the ATP of undetermined significance, which means in this category, the risk of malignancy is quite high, around 20%. So I will do a repeat an FNAC in them if possible, or if I do an imaging, most likely I do an MRI and then take them for surgery. The fourth category is we have 2 categories in that, 2 subdivisions in that, 4A and 4B. 4A means it's a neoplasm. They say it's a neoplasm which is benign. Again, they will go for surgery. Once they label it as benign on Milan, the risk of malignancy is less than 5%. You are sure that it's not malignant. And category 5B is that one what we call SAM, which is salivary gland neoplasms of uncertain malignant potential. Again here, the risk of malignancy is higher than the first one, that's non-diagnosed. It's around 35%. So you always operate such cases. And then category 5 is suspicious of malignancy. You operate them, but the risk of malignancy is 60%. And then there's a category 6, which is confirmed malignancy, then the risk of malignancy in such cases is around 90%. So these categories 2, 3, 4, and 5 you always operate. As far as imaging is concerned, I will always prefer an MRI, because MRI tells me some important things in this, and every healthcare should do an MRI if possible, because it has a better soft tissue delineation between the tumor and the normal tissues. It will define your deep lobe tumors very well. It will tell you information about the perineural invasion, and if there is a bone marrow infiltration. If there is an extracapsular spread, it will tell you information about it, and in especially recurrent tumors, because 50% of my load is a recurrent tumors. So I will always do an MRI. CT scan is good if I want to know the skull base infiltration or bone erosion. I never do ultrasound. Ultrasound I only use in screening. Screening means that if I want to distinguish between a parotid and a non-parotid tumor, I usually avoid ultrasound, but it helps in one category, that is children, because in children they will not tolerate a CT scan or an MRI. In such cases, I will prefer an ultrasonogram.
Correct. That is really fascinating to know about imaging and the importance of diagnosis also. Now, doctor, moving on to treatment strategies, what are the primary surgical and non-surgical options available for salivary gland tumors? Also, how do you determine the extent of surgery or need for adjuvant therapies such as radiotherapy or chemotherapy, especially in complex or recurrent cases? As you also mentioned, those are a high number of cases.
So, all salivary gland tumors are treated surgically.
Oh.
Why? Because surgery is the best thing that attempts curing them. Radiation, they are relatively radio-resistant. As primarily we don't use radiation, we use radiation in 2 settings. One is if in the adjuvant, if we have done surgery, then if it's a stage 3-4 disease, we do an additional treatment with the radiation. But or if it is an inoperable disease, like the disease has gone into the internal carotid artery or it has gone through the skull base into the brain. In such cases, we use only radiation as primary. Otherwise, it's all surgery. And regarding chemotherapy as of now is only of palliative. We use it in only palliative settings. That is, if the disease has gone beyond the hands of the surgeon, it's spread it's spread in those areas, like it has distant metastases, high grade disease. We only use it in palliative to give pain relief and other things to that. We don't have good chemotherapy drugs as of now for these. So it's all surgery. Now, targeted therapies are making inroads, but still they are in the clinical trial settings, and some drugs we are using. Now, if we say what type of surgery, if it is a minor salivary gland tumor, we use a wide local excision with the 1 centimeter margin. It's a minor salivary means if it's in the oral cavity, nose, or it's in the palate or some other place. But if it is a parotid, which 80% of the tumors are located in the parotid, then there are different surgeries we do for parotid. Let's concentrate on the parotid first, because it's a very important gland. So we do surgery, gross removal of the tumor with preservation of the function. Function means preservation of the seventh nerve or facial. Now, there are different surgeries, like if we are doing for a benign tumor or a very low grade tumor, we can do a partial parotidectomy or what we call extracapsular parotidectomy. Here, there are two criteria that are differentiated from the routine procedure, that is superficial parotidectomy. Superficial parotidectomy means identifying the nerve, preserving all branches, and removing the superficial bone. So, which is done most in T1 and T2 diseases too. Now, for extracapsular dissection, here we just hug the tumor. Just we go close to the tumor. We don't dissect the facial nerve. We just put on some loops, which is a magnifying, or we do it under microscopic control, and we don't identify the nerve. And if we see some branch, we'll identify and preserve. But I am little biased in this. I always prefer to dissect the nerve, but only if there's a tumor in the tail of the parotid. In such case, and that is a completely benign tumor or a very low grade tumor, then only I will do a adequate parotidectomy or what we call extracapsular parotidectomy. The rest of the cases, I always do a superficial parotidectomy, identify the nerve, and follow all the branches and remove the superficial. Now, T3, T4 tumors, we always do a total therapy, conservative therapy, which means we identify the nerve, remove the superficial lobe and deep lobe of the. But this is little controversial. If I have removed the tumor and I've done a super good superficial parotidectomy and I don't find any tumor on despite it being a high grade or it being a T3 and T4, I will never try to remove the deep lobe if it's not involved. Because the moment I try to remove the deep lobe, then the branches of the facial nerve are under stress and I may have some complication with the patient. So I always, if it is in the superficial lobe and I can dissect that all branches and remove it completely without seeing any gross tumor left, then I will do a superficial parotidectomy even in T3, T4 and high grade tumors. Now, there are other procedures like we do a total radical parotidectomy where we remove the facial nerves. Where if I see grossly that facial nerve is being infiltrated by the tumor, I will not hesitate in removing that branch of the facial nerve which is being infiltrated, or if the trunk even is infiltrated, I'll remove the infiltrated, and then I will do a cable graft, which most commonly I use a greater auricular nerve to graft that and each ends after finding the both ends of the facial nerve. So this is one, and then there's an extended radical parotidectomy where if the skin is involved, if the mandible is involved, if the masseter is involved, or temporal bone is involved, then we additionally remove those structures which are involved by the tumor. That we label as an extended radical parotidectomy.
Yes, I think that provides a great perspective on all. I think tailoring treatments on individual cases is also important, I feel.
One more question that arises in case of surgery is how much is the margin? That's always there's a discussion. So what we know is that 1 mm margin is enough in the parotid, If we have less than 1 mm, that means positive, then we should try. In such cases, a frozen helps us. If we remove that area and we see there is a margin is free, then we can leave that. If the no gross tumor is on that area, and
Correct.
1 mm is quite enough. You can do it in high T3, T4, even high grade, and then add the radiation therapy. You can have similar controls even without damaging the facial nerve.
So now, doctor, since salivary tumors are very closely related to facial nerve, so treatment often brings up concerns about nerve preservation and aesthetics also. So how do you address these concerns during treatment planning, and what strategies do you recommend for improving patient quality of life and long-term functional outcomes?
No, I will not go into the theater without assessing the facial nerve of a patient. I will again always do a good imaging, which is an MRI, which tells me a lot about where the tumor is, what is the extension, is there an extracapsular spread of the tumor. That gives us lot of information. So never go into the OT without assessing all these things. So then second thing is what happens is that there's an inadequate understanding of the biology of the tumor. That's what I am saying. Even if it's a T3, T4, and I get a free nerve, I get a one, I will not try to remove the deep nerve. That way, we can improve the quality of life of the patient and having the same results if we remove the deep nerve also. That's one. Second thing is that all surgeons should get trained because as I told you, they are rare tumors. So the per institution exposure is very less. But if you go to the institutions where the tumors are tumor volume is high, and you learn from the masters, then only embark on doing these surgeries and see how we can identify the nerve, how we even if it is involved, and how to preserve the significant branch and how not to preserve an insignificant branch. That way, we can help that reducing the morbidity to a lot of extent. Now we have intraoperative nerve monitors. We can anything happen, we go close to the nerve, they will beep up, and we can come that way. We can come to know that we are near close to the nerve, and that way we can avoid injury to these very vital branches of the facial nerve. Now, sometimes if there's a gross tumor infiltration, so that at that time it's not as advisable to save that branch. Then that branch can be resected and cable graft. Like I told you, we can put a nerve from a auricular nerve or some other nerve and use a cable graft. That will not restore the function what God has given you or what nature has given you, but at least that will give a tone to the muscles, and the functional outcomes will be much better.
Yeah, those are some really interesting strategies, doctor, that you mentioned. Now, are there any common misconceptions or gaps in training among healthcare professionals regarding salivary gland tumors, and how can these be addressed to improve care delivery?
I told you 2-3 times I mentioned that they are rare tumors, and individual surgeon or individual doctor having experience in large number of tumors is very less. And basically, they have to understand the biology of these. It's just for the younger generation surgeons who are going to do these surgeries. They should understand the biology of such tumors. They should not, without having an inadequate exposure to these complex surgeries, they should not embark on these surgeries. Visit a center which is having a lot of these procedures being done or done by good surgeons. Then only start doing all these surgeries. Otherwise, we will have a lot of complications. We will have a lot of and always try to it's a age of technology. So we have nerve monitors. Use these nerve monitors to identify these nerves. And first important thing is to learn. If you don't learn, don't do it.
I think continuous learning also seems to be a key in improving patient outcomes for surgeons. Now, finally, doctor, with advancements like robotic surgery, molecular diagnostics, and targeted therapies, which are rapidly changing the oncology landscape, how have these innovations impacted the management of salivary gland tumors, and are there any exciting research developments or clinical trials on this horizon?
Now, as far as robotic surgery is concerned, the advantage of robotic surgery is mainly avoiding all these scars. Now, I think
Hmm.
more of it, the robotic is in the minor salivary gland tumors. If it is a parapharyngeal tumor or it is an oropharyngeal, like it is a tumor in the tongue base or tonsil, we can go through the mouth and resect that tonsil without doing an external incision. And in parotid, we usually use an incision like preauricular incision and the neck. Now there is a something we can do it with the robot, that we use a retroauricular, which is retroauricular means behind the auricle we give an incision, and through the robot we can access these structures because the vision is very good, and there's a dexterity. You can rotate that robot
Hmm.
360 degrees and you can easily remove these tumors without giving a visible scar in such cases. This is the role of robotic surgery. It is evolving, and maybe under 10 years we may have many more things, much interesting things coming up. Now, as far as the targeted therapy is coming, there are multiple clinical trials going on, and now they are mainly concerning about targeting like estrogen receptors alpha or progesterone receptor on androgen receptors. And there are some drugs coming up which are being used, like transmap or deroxetican or bicalcumide or pembrolizumab or stiximab.
Yeah.
These are they are, but they are still in research, and some we use these pembrolizumab or stiximab we use in in advanced stages. But there is one phase 2 clinical trial that is going on, and that is targeting mainly the HER2 positive salivary gland tumors, which are positive for this receptor, targeting that with the trastuzumab, and plus we're giving the chemotherapy like doxycycline. It has been seen that there is some response around 70% of the tumors they respond, but how much is the response, and how much is the response, that needs to be seen. Only time will tell. And second thing, that the only thing that is wrong with these drugs is they cause a lot of side effects, like
Oh.
most of them either they'll have oral ulcerations, patient won't be able to tolerate the drugs, or they may have cell counts decrease, so the patient may not be able to tolerate it. This is a big hindrance for using these drugs. Although they are
Yeah.
showing promise, and maybe in future we may have good drugs which will not cause these side effects, and at the same time, if not reduce, at least keep the disease stable.
I think in future it might also help in just reducing these side effects also. Let's just hope for that. And I think robotic surgery has also become easier for surgeons as well, I feel. So it's really interesting to know about the future. So, Doctor, thank you so much for this enlightening conversation, and your expertise and insights into salivary gland tumors have provided invaluable takeaways for our listeners and especially even for me. So, thank you so much for joining us today, Doctor.
Thank you for.
And to our audience, thank you for tuning in. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay healthy.